We do all fertility treatments. We do fertility assessments, virtual consultations, egg freezing, embryo freezing. We do in vitro, donor egg, donor sperm. We do at-home testing. We do some gynecology for well-woman visits for people who need those, or urgent GYN visits. And we help out with, if you're not ready for a baby yet, but might be thinking about one in the future, we can help you with your birth control in the meantime. And we also offer quite a bit of counseling and support, because this is Mental Health Awareness Week. That's what we're going to be talking about here. We're on a mission to educate, empower, and teach you, give you the knowledge and information you need to make the best decisions for your life. That's what we want to do, and we want to include anyone who wants a child in their future. So it's important, we think, to start with the basics, Fertility 101. And the reason for that is we're taught our entire life how not to get pregnant. But when we're ready, we don't know where to begin. We think, well, we'll fool around and, it should just happen. It's supposed to be easy. That's why we work so hard not to get pregnant all those years. And then we don't really even know what to do when things aren't going as smoothly or as quickly as we think they ought to. And we want to make that right. When it comes to fertility, the most important thing you need to know is you need to think about your age and your goals. So I talk about this every single day, probably 5, 6, 7 times a day, but we're born with all the eggs we're ever going to have. And by the time we go through menopause, those eggs are gone. So we're born with about 1 to 2 million eggs. And by the time we start puberty, we're down to about 400,000 eggs. And people just are shocked by that you've already wasted so many eggs. And we think that's not fair either. But depending on, regardless on what's going on in our lives, we continue to kind of go through about 1,000 eggs per month. And these eggs are really tiny. We can't see them with the naked eye. We can't really look at them and count them, but we know about 1,000 eggs per month go. And out of that 1,000 eggs per month, there's a small group of eggs that is allowed by your body to try to ovulate and maybe create a pregnancy. That small group of eggs is called a cohort, and those eggs that grow big enough in the cohort that we can actually even see them on ultrasound are called follicles. There's an egg with a small fluid-filled sac around it. By the time you're 35, fertility declines. And so why is 35 such an important age? Well, it's not like a switch. The fertility declines gradually over time, but it starts to decline more rapidly about the age of 35. And 1 out of 10 women will actually experience a diminished ovarian reserve or a low egg count even before they turn 35. And we want to know if that's what's going on with you, because there might be things we can do to help you ensure that you can have a child when you're ready for that. Not only does the egg number decline over time, but the egg quality declines over time too. And poor egg quality means that the eggs are less likely to fertilize well or fertilize normally, so they're more likely to have abnormal chromosomes and result in either a miscarriage or not get you pregnant at all. Even if the chromosomes are normal, the other things in the egg quality as the egg ages, because remember, it's been there as long as you have, might make the egg not divide well into cells and make embryos that are nice and clean and able to implant. But we think you're never too young or too old to learn more about your fertility and how your body works and where things stand. You can be proactive. So one of the things to know is when you're most fertile. When you're trying to get pregnant, how do you know when you're most fertile? So if you look at this little calendar here, that red dot, that's, the day your period starts. And then approximately 2 weeks later is about when you're going to ovulate. So for the 4 or 5 days before you ovulate, that's your most fertile time. And if you use an ovulation prediction kit and test for ovulation, your ovulation kit will turn positive the day before actual ovulation. So the day before ovulation or the day before your kit, or the day your kit turns positive, sorry, and the day of ovulation is those are your very most fertile days, but you're also fairly fertile a few days before. You're really only fertile about 4 or 5 days a month, and the rest of the time you're not. So that's important to know, and you can use that information to time intercourse for when you want to get pregnant or when you want to avoid it. Other things that impact your fertility are your lifestyle, healthy diet, exercise. Marijuana and cigarette smoking are not great for eggs. Excessive use of alcohol also is not great for eggs. Some supplements people take to improve their egg quality, but it's important to talk to a doctor who's knowledgeable about that, because some supplements will actually keep you from getting pregnant, even though they're marketed to improve your fertility. Family history is important, and mental health is important too, not because it affects your eggs so much, but because fertility and stress are so intricately tied together. One affects the other. It's all one thing. The actual definition of infertility is the inability to get pregnant after a year of not using birth control. So some people will say, well, we haven't used birth control in 2 years, but we've only really been trying for 8 months. And I say, well, what does that mean? And they'll say, well, now we use the ovulation kits and we make sure we do things at the right time. And sometimes they say, well, my husband was out of the country until 8 months ago. So you have to be together and having regular sex, but you don't have to be, doing extra things to count as trying by the definition of infertility. So about 1 in 8 couples experience infertility. That number goes to 1 in 3 over the age of 35, and it goes to 2 in 3 over the age of 40. And about 1/3 of infertility cases are male, so it is not just a women's problem. It's about 1/3 female, 1/3 male, and 1/3 are both. So definitely both partners need to be evaluated. If you're over 35, because 1 in 3 experience infertility at that point, then we recommend you should actually be evaluated if you've been trying for longer than 6 months. There's no magic formula to getting you pregnant when you're ready to get pregnant. It's just a matter of giving you the information and doing a proper assessment, talking with somebody who is able to help you navigate these questions, to learn more about where you stand and to make good decisions for yourself. So here's some things you can do. One of the things we do at Kindbody is a fertility assessment, and it's a one-on-one consultation with a fertility specialist. We discuss your medical history, your family planning goals. We do an ultrasound to count those follicles, and we usually recommend a blood test called anti-Müllerian hormone. And then we come up with a personalized plan and next steps established based on the consultation. The ultrasound is a vaginal ultrasound. It's painless. And we also can look at things like, do you have cysts on your ovaries or fibroids in the uterus? Are there any other problems that we can see that might be affecting your fertility? And we often check other hormones, but AMH, anti-Müllerian hormone, is the most important one. The fertility assessment kind of tells us about the quantity of your eggs. It doesn't tell us about quality. Quality is harder to figure out. If you have a baby, that was a good egg. If you do in vitro and we look at the eggs under the microscope and we see how they fertilize and then we see how the fertilized eggs grow into an embryo, and then we test the embryo and see if we have normal chromosomes. Well, those every step of the way can give us quality information. But it's really hard to do a simple test for quality. So if you do come in for a fertility assessment, you will have options moving forward. You can wait, you can freeze some eggs to ensure that you're able to have a child when you're ready. And we can help you figure out what the right number of eggs to freeze should be based on your age and based on your egg number. A good AMH is 1 to 6. Somebody asked that question, just popped up. You can freeze embryos, which is fertilized eggs. We can just get started with fertility treatments or third-party reproduction, depending on what you need. So what is egg freezing? Egg freezing is extracting eggs from your ovaries and freezing them for later use. So in order to get the eggs frozen, we have to ripen them up and go through a process. Before you freeze eggs, you need to answer some questions for yourself. Should you consider egg freezing? Next slide, please. Thank you. So these 4 questions are: how old are you? How many kids in your ideal family? How old do you want to be when you have your first child? And how old do you want to be when you have your last child? Like, when do you want to close up shop? Basically, the bigger those numbers are to each of those questions, the more you should think about freezing eggs, because your eggs are the best they're ever going to be and the most they're ever going to be right now. So if you say, well, I want 3 kids and I don't want to start having kids until I'm 33 and I'm 27 now, you might want to freeze some eggs just to ensure that at least you don't have trouble having your second or third child, you know. And most women will actually try on their own with simpler things like having sex or simple fertility treatments before they use their frozen eggs. But it's nice to have them if you need them. And most of them hold those on for their later cycles. So how does it work? Remember, I talked about the cohort, right? The group of eggs that's like a team that gets to go out on the playing field and play. They get to try to make a baby. Well, normally you ovulate one of those eggs. And what we try to do with fertility medications is we try to ripen up more of the eggs in that cohort. So we're not using up your eggs. We're just recruiting more eggs from the cohort that you have. So we give you this hormone called FSH that is made by your brain to ripen up one egg. I'm still on with fertility care. If you can back up the slide just a little bit. Thank you. We give FSH, and what that does is that is the same hormone your brain uses to stimulate growth of one egg, but we give you a higher dose of that so more eggs get a chance to respond to it. Next slide. You take this medication has to be given by injection, I'm sorry to say. So you have to take daily injections for about 10 days to help this batch of eggs mature. And during that period of time, we monitor you closely. So you'll come to the office between 4 and 6 times for short visits that are an ultrasound to check the growth of your eggs and blood work to check the dose of your medication. Our goal is to get as many eggs as we can that are healthy and mature so that we can minimize the number of egg retrievals you need to do to get your ideal family. Next. So if you look at this calendar, what usually happens is we'll stop the birth control. We usually use birth control pills or some other medication to line up all the follicles about the same size so that they'll respond the same amount to the fertility meds. So if you look at this calendar, we usually stop birth control pills on a Sunday, start your fertility meds on a Friday, and then you're taking your medications and coming in for visits until the eggs are mature. Once the eggs are mature, then we give you a different medicine called a trigger shot. And what that shot does is it loosens up the egg from the wall of the ovary so that we can get it out more easily. If we didn't do the trigger shot, the egg would stay tightly attached to the ovary or the wall of the follicle, and we would get it out. If we wait too long after the trigger shot, you'll ovulate and then the egg is gone. So we need to time that just exactly right. And then the egg retrieval is about, we can go to the next slide, please. The egg retrieval is about a 10 to 15 minute procedure. You have light anesthesia and an IV. It's a needle stick. It does go through the vagina into the ovary, so you wouldn't want to feel that, but we use ultrasound to guide the needle into the ovary and remove the eggs. And when you wake up, what you're recovering from is just a needle stick on each side. Next slide. So egg freezing allows you to freeze eggs that can be fertilized later with sperm. Embryo freezing means that we take the eggs and we fertilize them with sperm right away and grow them in the lab for about 5 or 6 days to what we call the blastocyst stage, which is a ball of about 100 to 200 cells. And at that point, the embryo can be frozen. And it also allows us to test the embryo for genetic or chromosomal problems. Neither one is better than the other. Egg freezing is less costly because we're not doing all the lab things. And it allows you flexibility in terms of what sperm are you going to use to fertilize the eggs. Embryo freezing allows testing of embryos for problems, so you know what you have to work with before you decide if you want to freeze anymore, but you are committed to that sperm. Once the eggs and embryos are frozen, they can be stored for as long as you like. So eggs can be frozen for decades. There are literally cases of children being born from frozen embryos that were frozen 25 years ago. So, and that was with old technology. With new technology, we don't know what the limit is yet. Our hope is that you'll get pregnant naturally. You won't need your eggs, but they're there if you need them. The way that we use frozen eggs is IVF. So remember, I talked a little bit about fertilizing the eggs with sperm and then growing them in culture. That's how that works. And then the embryo can be transferred into your uterus. So the way that that works is we prepare your body before we thaw the eggs with estrogen and progesterone. There's usually a couple of visits during that period of time to start those 2 different medications. And then we check your uterus and make sure it looks like it's healthy and the lining is good, a good place for an embryo to grow. And then we do an embryo transfer, which is very, very simple. It's like kind of like a pap smear. We place a speculum in the vagina and thread a thin, little, soft, flexible plastic tube inside the uterus that has 1 embryo in it. And it's a painless procedure. And we transfer the embryo, and then 9 days later, you find out if you were pregnant. So that part is very simple to do. So summing up, there's lots of paths to parenthood. There isn't a right one or a wrong one. Some people get pregnant on their own. Some people need IUI or donor sperm. Some people need in vitro. Some people need donor egg and donor sperm with in vitro. Some need fertility medication. We call that ovulation induction. Whether you are using your own eggs or sperm, you're using a carrier or you're carrying the baby yourself, there's no right or wrong option. All options are available to you. We're just here to help you find the right one for you. And now I'd like to turn this over to Maya. Maya, are you able to?
There we go. Somebody had to unmute me.
Okay, yeah.
Hi, everyone. I'm Maya. Photo of myself in my younger days here. But I'm a therapist and I specialize in supporting patients who are going through a fertility process or building their family in alternative ways. I'm also a co-founder of Empower with Moxie, which is focused on education and embryo donation. And it was interesting because that last slide had family building options and embryo donation wasn't actually on there. And it wasn't on my list either at the time. And I'm actually a parent through embryo donation. And I work in this space to support patients going through things. I did also make a film that was added here that's on Vimeo on demand called One More Shot that is highlighting my journey to parenthood, which, like I said, spoiler alert, but ended with the birth of my daughter through embryo donation. But I'm going to focus a little bit on just the mental health aspect. And I have to say, just watching this and listening to you, Dr. Kane, I was a patient, a fertility patient myself in like 2012 to 2015. And I did not have this kind of information or a clinic like Kindbody that really sees the whole patient and that understands that a fertility journey, whether that's an alternative path to parenthood or different assisted reproductive technologies, it not just isn't always straightforward, but it's also not just a medical issue. It's an emotional issue. It's a relational issue. There are just so many, it's a financial issue for a lot of people, which becomes a relational issue. It can just be really challenging for people. And the fact that Kindbody integrates all of these services and connects OB to RE and to reproductive endocrinology and includes everything from acupuncture to an adoption counselor. I'm just mentioning these because I know these are some of the ancillary services: nutrition support, yoga, meditation, and of course, therapy and counseling support for third party, anybody moving towards third party, but also just to support you along the way in any way that's needed. So here are just some stats and percentages. As you can see, really high depression, and even feelings of suicide for people going through fertility struggles. And this stat has been around for a long time about research showing that women with infertility have the anxiety and depression levels similar to those people going through cancer, heart disease, and various other really serious illnesses. Anxiety is really par for the course. It's very hard for a lot of people to sit with some of the unknowns that a journey to parenthood is kind of inherent, I guess, to say in a journey to parenthood. And I think there's also, so many people feel out of control. We feel isolated from our peer group sometimes. There are different cultural factors that play into it. But I also, when working with different clients on the mental health element of, just trying to cope with some of this stuff, what I notice more and more is there really is this gap between what one expected, or like how a person expects their family building to go, like a glass of wine and a night in bed type of thing, and then the reality of it. And that's true for just very different people, different populations building a family in different ways. I work with same-sex couples who surrogate has multiple miscarriages, and it brings up such feelings of, oh my gosh, we thought this was going to be easy because we have a young egg donor and a surrogate, and yet it's experiencing fertility and infertility through somebody else's body almost, right? And so there are a lot of different factors. But I think this is really a slide that normalizes that having big feelings is really can be part of this journey as well. And we want to support people through that. And building your village. And it is so important to build your team. And I think, you know, I work with so many different people who just feel so isolated from their group. But since the days that I was a fertility patient, I do see more and more specific kinds of support. There are groups for single moms by choice that I have different people who are, you know, part of these different groups. I think it's called singlemomsbychoice.org or choicemoms.org. And there are meetups that people are doing, you know, Kind Body's doing these kinds of presentations. There are, you know, 80 plus people here today. So everybody, even if you don't know each other, you're connected through an interest and through a possible shared experience. Resolve sometimes does different support groups. So just finding your people and people that you can connect to is just a really important part of decreasing a sense of isolation. Key stressors. So this is sort of like warning, right? I mean, if you're going into IVF, chances are you've already done some things to get to that point that have already been stressful or perhaps anxiety producing in some way. A lot of people aren't really comfortable with injections, especially when you're doing them on your own at home at night when the clinic is not open. And I'm sure there are ways for people to get help. And I know Kind Body, I think, makes videos and different tools to help support that process, which I would have loved to have years ago. But there are these specific days that can really be trigger days, for lack of a better word. But the first day of injections, doing it for the first time, the night before the retrieval, and just the waiting for when you're going to go get your HCG, waiting for your embryos to fertilize, to know how many embryos there are, now waiting for PGT testing, genetic testing, waiting for your embryos to come back. And, you know, I think there are just, these are key days, but there are different stressors all over the place. And it's important to understand those so that you can utilize specific coping tools to get through some of those days. Additional stressors, just being in the world sometimes can be an additional stressor. And I mean, social media can be really hard for people. Pressure from friends and family or people that just don't get it, or anybody telling you just to relax and you'll get pregnant, you know, celebrity type of thing. So obviously there are just a lot of different, and I think now also, you know, we've been living through this pandemic that has added a base layer for so many people. When the clinics closed, that was really stressful for a lot of people, right? And so there are just a lot of different elements on top of, you know, just the fertility stuff. And I think, you know, again, this idea of understanding that there are over 7 million American, that's the stat, right? It's a very old stat, Dr. K, maybe you know, but this stat was from 2012, I remember, because it's been around like 7.1 million Americans suffer with fertility treatments. And it is higher than that, most likely, right? Do you know a more recent stat?
I think so. That's probably the number of people who actually were going through fertility treatment, but the number of people with infertility is much, much higher.
Much higher, right? And so we're really talking about millions of people around the world who are experiencing this. And now that we've gone so virtual, I think it's a little bit easier to connect and to learn and to find your support team. But I think it's just so important that people know they're not alone. Oh, here it is. Wait, 186 million individuals experience infertility. That's a big number. And you know, and I think it's important. I think this was on one of the earlier slides that Dr. King shared, but that male factor infertility is really present as well. I think for a long time it just wasn't talked about as much. And it's important to acknowledge that men and women experience fertility challenges. But yeah, if you take this number in for a second, you can go, wow, how come I feel so alone, and yet 186 million other people are having similar experiences. Normalizing the conversation. Yeah, I mean, that's what we're doing. I think, you know, early early days of this, I think there was different kind of stigma and shame, but I've really, since I've kind of been in this work and in this world as both a patient and professional for over a decade, I do see that it's really changed. And I think that it's more normal to have a fertility issue than not, I think, in some ways. And just being really open to learning about the different ways that families can come together, whether that's with the help of a surrogate or a gamete donor in some way, through adoption, if you move in that direction. Deciding not to have children after a journey is also a resolution. So I think just normalizing that sometimes we have to think outside the box, and sometimes it's an unexpected kind of left turn that a lot of us go on. But that being able to connect and talk about it and kind of break that silence is just really important. And we hope that Kindbody is helping with some of that. Talking about infertility with friends and family. You know, I talk sometimes when I do these third-party consultations about the difference between secrecy and privacy. And I think sometimes when we have secrets, when we feel like we're keeping our fertility journey or our challenges a secret, it really drums up feelings of shame. And I think it's so important for us not to feel ashamed. Fertility issues are a medical diagnosis. And I think it's frustrating sometimes when there's not a lot of insurance coverage for that, but it is a medical diagnosis, and even unexplained infertility is a medical diagnosis. And so, you know, really getting comfortable with, okay, what do I want to keep private? And what could help me by sharing, and really being able to set your boundaries together if you're partnered, decide what you're comfortable sharing, what you want to keep private, to who you share, to whom you share. And knowing that you don't have to put yourself out for other people necessarily, if that makes sense. Sometimes it's about having the right time, and sometimes also sharing can help people give you the support that you need. I think for people who have friends and family that kind of don't understand this world and this process, people can give unsolicited, super unhelpful advice that is upsetting. So being able to really connect to what it is you need from people, and then sharing that and advocating for yourself in that way, can be really helpful when dealing with family and friends. And then, of course, there's professional support. This is what I do all day, every day. And I love the work that I do. And I think it's really important to have professional therapists who understand this landscape and this language to support you. Kindbody has therapists licensed in all the different states that they are have clinics in. And so they're, you know, you can book an appointment, and hopefully it's a fairly simple process. So these are some of the things that we focus on in some of these sessions, you know, basic stress, really talking about coping. How do you manage some of the feelings that come up? Grief, and I think I would expand on that. And it's not just grieving after a miscarriage or a transfer that isn't successful, but there are a lot of different types of grief that people experience. You know, there's like the grief of lost time. People who are in this for years and feel like they're, you know, really kind of pushed up against the wall. There's genetic loss if you're, you know, working with a donor of some sort. There's grief when you're maybe not carrying a pregnancy. So there are a lot of different places where grief comes into play. And I think at the very basic, it's like grief that you have to do this in a doctor's office, right? And so again, it goes back to these unexpected life turns that happen. Emotional challenges, right, with donor conception. And then, you know, navigating intimacy, it just can be really hard. There's so much of this, so much pressure sometimes when it comes to that. And so sometimes just really building space to connect to yourself, to connect to your partner, to be intimate when you know you can't get pregnant, so that there's less pressure around that, and just to find different ways to connect it and find that intimacy. What now? There's no magic formula. I think this is a slide I've seen before, right? I think part of this too, oh, that's okay. that wasn't a negative comment. It's just reiterating that you have to advocate for yourself. Nobody knows you like you do. So being able to express what you need, I think Kind Body services are so multifaceted that people will try to figure out the right formula for you and the right supports. Yeah, knowledge is power. So, and that's why it's like, I don't know, I was just taking this in for a second as Dr. Kane was presenting, because I did not have a lot of knowledge in 2012 when I spent 2 years trying to conceive naturally. I didn't know what any tests were, and my OB didn't know either, apparently. And, you know, it's just such an amazing thing to see, like a calendar set up like that. There are certain tools that can help decrease some of the stress and anxiety. And part of that is knowing what comes next, right? So the fact that Dr. Kane, you just shared this beautiful calendar, and like, these are your fertile days, and this is what the IVF process looks like. I mean, that's going like, oh, okay, I get it. This is what it looks like. I think it's important to remember to be flexible, because not everything goes as neatly as the calendar states, right? So you have to be kind of mentally flexible with that, but just knowing that as a patient, I think just that can be such an important tool to have.
Thank you so much, Maya. Did you want to close before I take over here?
No, I think I saw some questions pop up, so I assume we're going to get to that, because I want to make sure we have time for that. And I apologize if I talk too much. I can't see my clock, and I do talk a lot, so please.
No, you're
I'll
great.
mute myself, but you have to unmute me if I have to talk again.
Thank you. Maya, I would just leave yourself unmuted. It's just a whole thing here. I'm gonna. Just because it's a whole thing. Thank you everybody so much. So we are definitely going to get to some questions, but I just wanted to touch on this code. Thank you so much for joining us. You can use code May22 to get the following discounts on some services. So we will be sending a follow-up email with all this information. So no need to scribble down notes. We will get it to you. We'll also get the recording of the session to you. So not to worry about that. And now let's get to some questions that we have in the chat, and please keep dropping them in if you have more. So for Dr. Kane, are you able to freeze your eggs when you're on Accutane or some kind of medication like that? I know you can't get pregnant on it, so I assume you wouldn't be able or shouldn't be able to freeze your eggs either.
That's a really good question, which is what doctors say when we don't really know the answer. So usually what I tell people with something like that, where we know it's really toxic when you're actually pregnant, is we usually ask you to stop it during the cycle that you're doing egg freezing. And the same goes for things like spironolactone. Typically, I'll ask people to stop those medications, those acne medications, or Retin-A, you know, during when you start the usually the pill or whatever we're giving you to lead in until the eggs are retrieved, and then you can go back on them right after the retrieval.
Great. What protocol is provided for thin uterine lining if estrogen does not help?
We have a few tricks up our sleeve. We just we have about 30 doctors now at Kind Body, reproductive endocrinologists. We meet every week and chit chat and talk about things that we're going to do to improve processes in the clinic. And we talk about, you know, challenging patients. And we were just talking about thin uterine lining. And there are things that we can do besides adding more estrogen. There's other medications that can be added, like Trental or Neupogen, to thicken up the uterine lining. You know, we can look at other things as well, but those are a few options. Sometimes you need a hysteroscopy to take a good look. Maybe the lining's thin because there's scar tissue. So we have a few different things that we can do.
Great. This is probably a question for both of you. So this is from, and a few people seconded this question. Can you talk about how mental health issues are triggered by injection and hormone treatments during fertility treatment? I know people who have gone through fertility treatment and seem to be on an emotional roller coaster because of the way the hormone treatments impact their body. Can you talk about this more?
I can tell you about the medical side of things, and then Maya can tell you about the emotional side of things. I think on the medical side, patients on the injectable medications in general seem to have fewer mood symptoms and side effects than they do on the oral medications like Clomid and Femara. It's not 100%. People still do experience that, but from the medications themselves, it seems to be less of a side effect from the injectable meds. However, there's an emotional side to doing IVF and egg freezing because it's a stressful process. So maybe Maya can talk a little bit about that.
Yeah, I think, everybody's body is really different. Everybody's more sensitive to hormones in different ways. And I think knowing yourself and your baseline, and then just remembering that when you're taking medication, you may be what I like to call hormonally compromised. So to just give yourself a little bit of space and grace in those time periods, we don't know how we're going to react. And it's really interesting, and I'm sure you see this too, Dr. Kane, but I work with so many people who have a history of anxiety or depression, and they're so worried about medications. And then it's like, oh, I did just fine. And I was expecting this, but I was fine. And then other people who maybe don't have a lot, they're just feeling super down, right? And so I think everybody's body reacts differently, and just understanding that. And it's, the other part is it's temporary. It's right. It's, whatever that 2-3 week period is, just understanding, okay, I'm going to be maybe hormonally compromised here. If I say things that are, not so nice to my partner, or,
Sorry for the things I said when I was on Clomid.
Right. I mean, I made a rule like nothing counts after 10 p.m. right? Like just because that's my time to be tired. And if I'm awake, that, it's not gonna be so good. So if you're hormonally compromised, and you can kind of have a little bit of a sense of humor about it, and just say, okay, we're going to board up the windows, and I'm going to utilize all of my coping tools, whether that's going for a walk, yoga, scheduling times to be with friends, feeling connected, self-care, retail therapy, online shopping, whatever it is you need, just knowing that you might have to give yourself a little more care and love and support and forgiveness from the people around you, etc.
Great, thank you so much. So Dr. Kane, are you able to undergo egg freezing and embryo freezing at the same time?
So to do that, what you do is you do the same process to freeze, to get the eggs, and then you take some of them and fertilize them with sperm, and some you freeze as eggs, unfertilized. And what's nice about that is it gives you some embryos to look at if you want to test them and see what you've got to work with, and still gives you some eggs that are just yours. If you create embryos with somebody who's not a sperm donor, a partner, he now has equal say as to what happens to those embryos. So yeah, this is an option for you, and an option that quite a few people take, especially if they have enough eggs to work with to do that. And we have a way to, make those orders stick in the computer. When we put the orders in, we'd say, we'll fertilize this many eggs and freeze this many unfertilized. Some people also like to do it that way because, for personal reasons or religious reasons, they don't want to have a lot of embryos stored, but they want some. So some people will leave some eggs unfertilized for those reasons.
Yeah, that's such an important part that not a lot of people think about, that if you have the potential to make a lot of embryos, that you might have what's known as a disposition dilemma on the back end, what to do with so many remaining embryos. So just knowing that people have a choice on the front end is such an important, is important information, so people can make those informed decisions for themselves.
Absolutely. Okay, let's take a few more. Let's see. So does Kind Body support with medical trauma before birth, PTSD, et cetera, or give recommendations for doulas who can assist during birth? Well, I can answer that. Yes. Kind Body supports you from preconception to postpartum. We have lactation specialists, doulas, therapists like Maya. Those are all part of our Kind Body 360 branch. So that is, you can book right now on our website, and that is absolutely there for you. We're here to support. Let me ask another one. Dr. Kane, does somebody, if they're currently not on birth control, do they need to go on birth control to prep their body for egg freezing?
Sometimes we find that birth control is the easiest, cheapest, simplest way of getting your eggs kind of lined up. So if we're using it, we use it for about 10 to 20 days. It's not a lot, you know, it's less than 1 pack of pills typically. But not everyone needs birth control or should be on birth control before freezing their eggs or doing IVF. Sometimes we start the fertility medication process at a different point in the cycle where the eggs are naturally all kind of the same size. Sometimes people have a medical contraindication to birth control pills or other hormone birth control. Some people already have an IUD in place and we just start whenever we want to start and don't even take the IUD out. And some people we use other medications like estrogen or progesterone to prime the cycle. So we have a lot of options depending on what your needs are.
Yes. So Maya, we have another question here more for your end. So this participant is saying, as her egg retrieval looms closer, she's worried about how many genetically viable embryos that they'll be able to get. Are there any suggestions for navigating this part of IVF?
That's that waiting, one of those waiting trigger points where anxiety and anticipation anxiety, it's really normal and common to be really high. I'm seeing this comment as well, and it sounds like this person has not had the emotional roller coaster, and what she's saying is that taking it one day at a time has been helpful. It's kind of like you have to kick that same mindfulness, present focused mentality into just another gear when it comes to waiting for genetically viable embryos. You know that you've done everything that you could have done by that point. The doctors have done everything that they could have done, and that it's just trying to, sometimes you have to just distract yourself from waiting, but those embryos will come back. I can't remember, is it like a week to 10 days when you send them away for genetic testing?
Well, we don't send the embryos away. The embryo is a ball of cells, maybe 100 cells.
Yes.
3 or 4, and then freeze the embryo. So the embryo stays put.
The embryo stays, right, sorry.
But it can be a couple of weeks to get those results back, and that can be a really long wait.
Yeah, so it's a couple of weeks. Okay, so it's similar to it was a while back. And that's just, it's just hard. And I would just say, whatever your coping tools are, supersize them. And just really trying to stay present in what and it's going to be whatever it is, and knowing that you have the strength and the support to get through it. And if you're open to how your family comes to you, that there are more options on the other side of whatever those results are. But that sort of day by day, moment by moment, present focused stuff sometimes can be the only thing that helps you kind of get through some of those moments.
Yeah. Okay, let's take a couple more and then we'll close up. And always feel free to, if your question didn't get answered today, always feel free to DM the Kindbody Instagram account and we will try and get those answered for you. We'll send them to a physician or any of our fertility experts around. We will get your questions answered. So let's take a few more. There was 2 more that I saw. So one person asked, Dr. Kane, you mentioned supplements. She said that there was a mention of supplements that aren't actually great for fertility. What are those?
Well, I always gently guide people away from things like Vitex, red raspberry leaf, fenugreek for men because it can actually inhibit sperm production, T boosters for men. Vitex is also called chasteberry because it used to make women appear to be chaste because it brought your period on. So for people who take Vitex, it's great for your cycle. People have irregular cycles and they take this. They're like, this is the best thing ever. But it doesn't actually make you ovulate any more than a birth control makes you ovulate. So it can actually prevent you from getting pregnant. Red raspberry leaf causes uterine contractions. So it's given to women in the 3rd trimester to help induce labor, but that's not exactly what you want when you're getting pregnant or in your 1st trimester where it can actually cause a miscarriage. So.
Yeah.
those are two examples off the top of my head.
And here's an interesting question that we often get. Are there higher chances of having multiples, twins, triplets using one treatment process over another?
Definitely, because IVF used to be the higher risk, but now we've gotten better at our job and we transfer only one embryo at a time. And that is giving us the same chance of success as transferring more and a lower chance of complications. So we typically recommend transferring only one embryo at a time, and twins are back down to about a 1% risk with that. But with insemination, there's still about a 5 to 10% chance of twins with fertility pills and insemination. So that's the higher chance.
Okay, great. Thank you so much. I think we should just wrap things up now. Let's just, would someone just follow up to that question? Let's let you finish. So could you choose to try and have multiples if you wanted?
So that requires a careful discussion. You know, why do you want to do this? What's your body like? What's your health like? What are your risks? You need to know what all of them are. We need to know what all of them are. It's not something that's undertaken lightly because there is quite a significantly higher risk of preterm delivery. Half of all twin pregnancies deliver prematurely. With preterm delivery comes increased risk of cerebral palsy, respiratory problems, retinopathy of prematurity, and OB problems like preeclampsia, high blood pressure, gestational diabetes. All of those things are increased risk with a twin pregnancy, and you're at a higher risk of miscarriage or losing the twins, one or both of them. So those things would require a really intense discussion. It's not never. Sometimes we do in certain situations, but most of the time we recommend sticking with one.
Thank you.
And can I answer the men question? We have Kind Man at Kind Body. And Kind Man comes up every once in a while in one of these fertility one-on-ones too, but that's our male division, where we do male assessments and treatments with our urology team. And so, yeah, we have a lot for men.
Absolutely. Treat everyone.
Yep. And Kind at Home has a men's package too, the at-home testing.
Yes, we do have Kind Body at-home testing. So that's male and female fertility tests, blood tests, and that's a great first step if you're, either not near a Kind Body clinic or just want to get a quick snapshot and see where you are, and then maybe come in and follow up in clinic. So thank you so much, Dr. Kane and Maya. This was so informative, and really, I think everyone's going to be super grateful that they got to have those questions answered. Again, we will post this record. We were going to email everyone who joined a follow-up with the promo code and the recording of this session, so you can go back and look at the slides or, rewatch anything that you've missed. So thank you all for joining us, and we'll be back again next month with a new topic. So thank you so much, and have a good one.
And thank you, participants. This was a great group of participants. I could see you chatting with each other in the chat, helping each other out. Like, what an amazing group.
Yeah, it really is. So much support.
Yeah, it was great.
Take care. Thank you.
Thank you guys. Thank you so much.